This program is brought to you by Emory University.
All right, good morning. We were waiting on an audience at Clifton, and we now have one. Dr. Clements, thank you for coming. Our speaker this morning is Dr. Nick Shekiladze. Nick went to medical school in the Republic of Georgia, and then he matched in residency at Mercer in Savannah, and then in our clinical program, he's a second year with plans to stay here for his interventional cardiology fellowship. Nick's talk this morning is on constrictive pericarditis. Nick.
Thank you, George. Thank you, Dr. Clements, for being here. Good morning to everyone who's listening. The topic of my presentation today would be constrictive pericarditis. There's a few reasons I decided to choose this interesting topic. One is I think it has very interesting echo and invasive hemodynamics. I also think that it's quite high yield for the boards. You will get at least a couple of questions on constriction and mainly probably differentiation of constriction and restriction. And also, in my last month of cath, I've had 3 cases within 2 weeks that were clear constrictive pericarditis cases, which got me interested into this subject. So let's get started. I have no disclosures. This will be a content of my presentation. We'll talk about etiology, epidemiology, we'll spend most of the time discussing echo and invasive hemodynamics. We'll discuss constriction versus restriction physiology, types of constrictive pericarditis, and I have cases at the very end. So when I started working on this subject, I tried to find some guidelines, and really there's no ACC/HA guideline on management of pericardial disease, but there's a very nice document from a European Society of Cardiology published in 2015. It's very concise and it's a good reference article. American Society of Echocardiography has published a document which is a recommendation for multimodality imaging in patients with pericardial disease, also a very good resource for assessing hemodynamics from echo and invasive standpoint. So I'll be referencing a lot to these 2 documents. So pericardium is made of 2 layers, inner layer, visceral layer, which is made of mesothelial cells, and outer layer made mostly of collagen and elastic fibers. It's a thin vascular sac that surrounds the heart and portions of the great vessels, carries several functions. It prevents infection. It provides structural support to myocardium. It limits the acute distension of the cardiac chambers. It also has a small amount of pericardial fluid that helps lubricate the heart in the pericardium. When we talk about epidemiology, the 20th century has been a major transition from epidemiological standpoint. As you can see from this study, published in 1999, they compared 231 patients from 1936 to 1982 to late 20th century, 1985 to 1995. They found that there's been a transition in amount of cases in post-cardiac surgery constrictive pericarditis, and that's probably because of the advances in cardiothoracic surgery by itself. There's also been downtrend of idiopathic cases of constriction seen in this study. And you can see there's multiple causes. Essentially, anything that invades pericardium or any pericardial process can give you constrictive pericarditis. And you see some of the causes here as well, more miscellaneous like malignancy, uremic pericarditis, we see it rarely. The most common type would be idiopathic, but in developed countries nowadays, the most common type of constriction is post-cardiac surgery. In developing countries, it's still an infectious cause. Tuberculosis is prevalent. Sometimes you get bacterial purulent pericarditis as well. Here I just put three examples of different etiology of constriction. On the left side, you see a bacterial fibrinous pericarditis, constrictive pericarditis. In the middle, there's a cancer mesothelioma that encases the whole myocardium and gives constriction. And on the right side is a young gentleman with AML who had an infiltration of the cancer into the myocardium and pericardium, causing restriction and constriction. This is actually one of my cases that I'll be presenting at ACC next month. We sent it as a challenging case. There was a study from European side by Imazio et al., published in Circulation in 2011. They looked at 500 cases of first episode of acute pericarditis. They followed them prospectively with a median follow-up of 72 months, and they tried to identify which etiology most likely will develop constriction eventually. So they found most of the cases were idiopathic viral acute pericarditis. As you can see, the incidence was very low. So it's less than 1% that develop constriction after an episode of acute pericarditis. And that was true even for those who had recurrent acute pericarditis. The incidence was still pretty low. And as you go down this table, you will see that number of cases decrease from other etiologies. For example, connective tissue diseases and autoimmune, they have less number of patients that develop constriction. Less number that had acute pericarditis, but they had higher chances of developing constriction. So in general, we think risk of progression is less than 1% in viral and idiopathic pericarditis. It's about 2 to 5% in immune-mediated pericarditis, and about 20 to 30 in bacterial or fibrinous bacterial purulent cases. So this concept is yet to be proven, but there's a study that postulated that maybe there's some sort of mesothelial cell damage with pericardial insult that causes a cascade of reduction in tissue type plasminogen activator that reduces the fibrinolytic activity and promotes fibrinous inflammation and adhesion formation, which can lead to the constrictive pericarditis. And the cycle of injury can happen within days, months, and even years before presentation. And speaking of presentation, most of these patients present with symptoms of heart failure. You see about 6-7% based on this study from Mayo of 135 patients. And the heart failure symptoms are mostly right-sided. So you get a lot of bloating, abdominal fullness, early satiety, and symptoms of cardiac cirrhosis, lower extremity edema, and you can have protein-losing enteropathy as well. A lot of these patients get GI symptoms. They can get arrhythmias, and AFib is most common. Also, in some cases, you can have real anginal chest pain from compression of the coronaries. When you move on to physical exam, interestingly, vast majority have elevated JVD. And as we learn later in the presentation, there will be a Kussmaul sign, which is a characteristic to patients with constriction, but can see sometimes in restriction as well. Pericardial knock. This is actually an S3 sound, early diastolic S3 sound of rapid filling of the ventricle from the atria because of the rapid decel of rapid Y decel on that tracing. So interestingly, there was a study of about 523 patients that had surgically confirmed constrictive pericarditis, and they found that about 54 patients out of those 523 and 64, they had various GI and thoracic endoscopic procedures prior to referral to the center, and this was studied out of Mayo. That just tells you how challenging diagnosis can be of constriction. People start looking for other things because of multiple GI symptoms, and the most common incorrect diagnosis was restrictive cardiomyopathy in this full cohort. Now, so here I have two patients with constrictive pericarditis, and on the top I put right atrial tracings for comparison. On the left side, you see the normal tracing. So this atrial contraction, relaxation, and atrial filling and emptying. So this patient on the left and on the right, in fact, pay attention to distension of the jugular veins with inspiration. This is a classic for Kussmaul sign. And this happens because when you inspire, you increase the preload into the right side of the heart, where you already have high pressures that are constrained by the pericardium, and you have reversal of flow into your jugulars. And then the other thing that always you have to pay attention is how rapidly this JVD flattens. Okay, so rapid flattening of the JVD. I didn't know this, but apparently it's called Friedrich sign. So, and it's actually very apparent on this right picture here when you have distension of this EJ during inspiration and rapid deceleration. And you can see here on the hemodynamic tracing, this rapid Y decel is very, very characteristic for constriction. If in comparison to tamponade, there's completely opposite happens here. So you don't have a Y descent, you have blunting of the Y descent. You have inability to fill the right side of the heart because of constriction by the fluid around the heart. So RV is completely constricted, you're not able to fill it. Therefore, you have blunting of the Y. We'll discuss this in a little more detail later. So as we move on to diagnosis, like I said, the high clinical suspicion from getting a good H&P and physical exam is very important. You mostly look for signs and symptoms of right side heart failure. What you have is an impaired diastolic filling because of the constriction by the pericardium. And there's multiple tools you can assess this particular condition, and this will be echocardiographic assessment, cardiac cath hemodynamic assessment. You can use CT and MRI as an adjunct for your diagnosis. And always keep in mind the main differential would be restrictive cardiomyopathy. On the EKG, normally you don't see anything specific. You can have some STT changes. Occasionally you get low voltage and AFib in the later, more advanced cases, especially when you start seeing some atrial remodeling. In comparison to restrictive cardiomyopathy, where you see huge atria that sometimes are even bigger than the ventricles, in constriction, you may see atrial enlargement, but not to that extent as of restrictive cardiomyopathy. You normally see a normal cardiac size on the X-ray. Your EF is usually normal, and right ventricular function is usually normal. Sometimes in about 35 to 50% of cases, you can see pleural effusions. So interesting thing to note is that only 25 to 30% of patients with constriction will have calcifications in the pericardium. So the absence of calcification does not tell you anything about that patient doesn't have constriction, but presence of calcifications may make your clinical suspicion a little higher. And also they found that in about 28% of cases, the pericardial thickness can be normal, and the patient may still have a constriction. As you can see on these pictures, there's some dramatic calcifications mimicking the silhouette of the heart here, and this is a CT scan that shows calcifications in the left ventricular side here as well. CT is often used for surgical planning, not just for diagnosis, but even after the diagnosis is already established. Now, on MRI can be also very helpful for a couple of reasons. So one of them is you can see some hemodynamic effects on the MRI. Its temporal resolution is a little bit lower than echo, but at the same time you have a variety of windows that you can look at. So on the bottom here, this cine image of the MRI, it's a short axis through the LV and RV. Just pay attention that during inspiration, so this is the expiration, that during inspiration, what happens to the septum? So it shifts to the left. That's a pretty classic finding in a constrictive pericarditis, and that happens with respirophasic changes, not with the beat to beat. That's the important thing to note. The other thing the MRI can be helpful is to identify patients who may have reversible constriction. There was this small study of about only 29 patients who were confirmed constrictive pericarditis patients, and they were treated with anti-inflammatories. They all had MRIs and late gadolinium enhancement. About half of them had resolution, and what they found from this study is that after qualitative assessment of the LGE, they found that those who had higher LGE uptake had higher chance of reversibility. In fact, they found that if your LGE uptake is about 3 millimeters, you had about 86% sensitivity, 80% specificity to predict reversibility. So you look for the higher LGE uptake in patients, and you may actually try to empirically treat them with anti-inflammatories for about 3 months. And also what's interesting is in this case, they've used prednisone. So they went up front with the steroids, which, classic teaching is that we try to avoid steroids in acute pericarditis until later because of the high chance of recurrence. But in this case, they wanted to shut down the inflammation as soon as possible because constrictive pericarditis is not the disease that you want to wait for too long. Okay, so now let's move to physiology. I borrowed the schematics from Mayo Board Review, and we'll discuss what happens during the normal breathing pattern, and then we'll go into what happens during constriction. So in a normal patient, with each breath, you have drop in intrathoracic pressure as your chest cavity expands. This subtle drop is translated directly into pulmonary capillary bed, into the left atrium and the left ventricle. So normally you have subtle distension of the left ventricle to accommodate that extra volume that comes from the increased preload. And your gradient from pulmonary capillary wedge pressure to left atrium to left ventricle does not change. As we know that the flow happens inside the chambers by the gradient. So if you don't have change in the gradient, your mitral inflow doesn't change. This is what happens with every beat. So you don't have no variation in cardiac output or mitral inflow. In cases of constriction, now imagine you have the same breath, you have drop in intrathoracic pressure, drop in a pulmonary capillary pressure, and then the left ventricle is trying to accommodate that extra volume, but then it hits the fibrotic pericardium that doesn't let it distend or be more compliant to that extra volume. And what happens is your LV-EDP rises, left atrial pressure rises, and your gradient from pulmonary capillary pressure and left atrium and LV-EDP gets smaller. When you have smaller gradient, you have less flow. So this is why you see a decrease in mitral inflow velocity. Now let's look at it from right side of the heart and left side of the heart together. When you have, again, with the inspiration of constrictive pericarditis, that extra volume that goes into the right ventricle, normally right ventricle would distend and accommodate that extra preload. But because it can't do it in the cases of constriction, because it's encased into the heart pericardium, the pressure that's generated in the RV pushes the septum to the left side. And when it pushes the septum to the left side, it can also get away with it because you, at the same time, have low filling of the left side of the heart. So less filling of the left and extra pressure in the right, or high RV-EDP, pushes the septum to the left side. You also see decrease in the pulmonary venous flow, and you have decrease in the mitral inflow, as we mentioned. During expiration, the opposite happens. As your tricuspid valve is still open, that septum shifts to the right, and when it shifts to the right, that it gives this extra bump of the pressure to the right side of the system, and you get this early hepatic vein reversal, Doppler vein reversal, which is the most specific finding in a constrictive pericarditis. You don't see that in any other disease process, and it has to be early diastolic phenomena. And this happens because of the septal shift back to the right side. And you have reversal of the flows as well, so your mitral inflow now goes up again because your gradient is normal. And this is a cycle that perpetuates from beat to beat and from inspiration to expiration. So this tells you the relationship of intrathoracic pressure and intracardiac pressure. Now you see on the bottom I wrote here, what happens during inspiration, your mean right atrial pressure, mean wedge, RV-EDP, and LV-EDP equalize to pericardial pressure because that's the essentially the denominator of where the pressures will stay. So elevated and equalized cardiac pressures because of the total cardiac volume is determined by that pericardium. Okay, so that's where the equalization happens. Okay, so one thing I have mentioned earlier, but important to note, when we read echoes and we call it a septal bounce. So what we mean by that, usually sometimes there's a conduction abnormality, a left bundle branch block, and you can see the bouncing of the septum usually happens with beat to beat. In constrictive pericarditis, this septal shift happens with inspiration, not beat to beat. It's important to, when you look at the echoes, not to make that mistake or assumption. Sometimes it's called, in literature you can find it's called checking of the septum or bouncing or shuddering of the septum. So all these essentially mean the same. Now this is my favorite picture from the article, the review article published in Circulation by Dr. O and Syed. You can see here it's a multiple hemodynamic data that are superimposed on each other and or put into the inspiratory and cardiac cycle. So here you can see there's a mitral inflow by echo. There's a left ventricular pressure tracing. There's a wedge pressure tracing. On the bottom here is a MO through the long axis of the heart, and there's a respirometer at the bottom. Also, all these events happen in a real time. So with inspiration, what happens is you have blunting of the mitral inflow or decrease velocity of the mitral inflow at the same time when there's equalization of the wedge and LV EDP. And as you expire, you can see the gradient. Now there is a substantial gradient. And if you want to remember the number, it's more than 5 change in millimeters per mercury with inspiration and expiration that is indicative of constrictive pericarditis, or in fact indication, it's indicative of ventricular interdependence. Okay? And an M mode is actually a very good tool to assess the septal shift. It's present in about 80% of patients with constriction. You have this shift with inspiration. Obviously, you need to have a respirometer during the study when you do your echo. So with these findings, as we go into the echohemodynamics, clinical suspicion and echo sufficient in about 75% of patients, but that it should be a very good echocardiography study, and it's not really possible in every patient. In almost all constriction patients, you see some mitral and tricuspid inflow variation, and we said that it is because of the alternating mitral inflow or filling of the left heart or the right heart, but this is not specific to constriction, as you know. You can see that in many other conditions, like, for example, asthma or cardiac tamponade. So you can see that variation. It's not very specific to constriction itself. Okay, so this is a busy slide, but I think very informative. So in healthy patients, E prime of the lateral mitral and tricuspid annulus is about 25 to 50% higher than the medial annulus. So that's in the normal healthy patients. What you start seeing in constriction is that you have reversed values on the medial and lateral E prime. And this happens because if you pay attention to the right side, your lateral annulus is tethered by the fibrotic pericardium. So if you have tethering of the lateral annulus, the only way the heart can expand or contract is longitudinally. And it does so by increasing the E prime, or movement of the medial tissue Doppler signal. This is called annulus reversus. It's pretty characteristic for constrictive pericarditis, and actually one of the main criteria by echo to have diagnosis of constriction. Now, the other phenomenon that's also interesting, there's a small study of about 10 patients that they looked at the relationship of E to E prime to the wedge pressure. Now, under normal, when you read a normal echo, if you see higher E to E prime, we call that the patient has high filling pressures. So we'll say our assumption is that the patient has high LVEDP, has high left atrial pressure. What they found that in constriction, this is actually quite opposite. There's an inverse relationship to the wedge. And it's maybe a little hard concept to grasp, but if you think of it, when you have higher E prime, your ratio becomes lower. And basically, the lower your E prime is, that means there's less pressure that's driving that medial annulus. Now, if you have higher E prime, your ratio is going to be lower, but if your E prime is higher, that means there's a lot of pressure behind it that's driving that medial E prime. So, for example, this patient A and patient B here, patient A has E to E prime of 5, but then all these patients got the right heart cath, and they found that this patient had wedge of 31. And then they checked a different patient, and they found that his E to E prime was 17, also high, but not a, E to E prime of 17, which is higher than 15, but their wedge was high, but not as high as the other patient. Okay, so there is some inverse relationship, which is, I think it's a very interesting observation in the constriction. Okay, moving on to specific echo criteria. The study out of Mayo by Welch et al., they looked at all these parameters by echo, and they found 4 parameters in plethoric IVC. They found that if you combine 4 of these parameters and there's a dilated IVC, you have about 87% sensitivity in diagnosing constrictive pericarditis and about 91% specificity. And those 4 parameters are septal motion abnormality, as we discussed, the shift of the septum during inspiration, medial E prime of above 8 centimeters, restrictive mitral inflow velocity, or E to A over 1, and that particular hepatic diastolic reversal with expiration, that is early diastolic phenomena. So the most specific of these was hepatic vein diastolic reversal. Okay, so always make sure this, if you have a patient that you suspect constriction, that you get a full study with hepatic veins Dopplers as well. And I just put in the echo Doppler here on the bottom, just to demonstrate. This is a Doppler from the SVC, just to show you what Kussmaul sign is and how it's actually correlates very well with echo and hemodynamic assessment. So this notch right here, during inspiration, you have reversal of flow. On the top right here, there's this another study by Ha et al. They looked at E prime velocities in 3 different disease states: in constrictive pericarditis, in amyloid, and in restrictive cardiomyopathy. What's interesting in this study, as you can see, there's not much overlap of E prime velocity. So if you have 3 different patients and one of them has high E prime and you suspect all 3 have heart failure, it's unlikely to have high E prime velocities in patients with myocardial disease or restrictive cardiomyopathy. This is the algorithm that they proposed. This is a Mayo echo diagnostic criteria for constriction that they use at their hospital. And it's actually quite simple. When you see restrictive film pattern, E to A over 0.8 or 1, dilated IVC, you can follow this this side of the algorithm into further diagnosing the constriction. If you see the septal motion, and if you have high medial E prime, and then you demonstrate that you have hepatic and diastolic reversal, that's a definite constriction. Okay? And if there's a low medial E prime, that's likely to be restrictive cardiomyopathy. And this is just by echo. And if you have an excellent images and if you are if you're sure about your findings. Now this slide shows you differences between constriction and restriction. There's a there's a lot of differences by echo and by hemodynamics, but the sum of this are similar as well. So you can have some ventricular interdependence in restriction as well, but usually not. So mostly there's clear interdependence in constriction. There's clear septal shift with inspiration and constriction. If you look at the flows through the mitral, tricuspid, pulmonary, and hepatic flow, they are different in respiration with constriction and not in restriction. We already mentioned about atrial size, how it's much, much larger in restriction. LV and RV function are usually normal and usually reduced in a restriction. And then you don't really see equalization of the pressures, of the diastolic pressures in restriction, and this happened in constriction. Okay, some of the differences with the tamponade, with tamponade maybe a little bit harder to discern constriction and tamponade, but at the same time, you do have large pericardial effusion, so that's not really subtle. But also, there are some hemodynamic findings. Like, as I mentioned earlier, there's blunting of the Y descent on the right atrial pressure in tamponade, and there's rapid deceleration of the Y in constrictive pericarditis. Kussmaul's sign, usually not present in cardiac tamponade, but at the same time, pulsus paradoxus is very common. In fact, it's one of the physical findings that we have to obtain with the tamponade. And in constriction, the pulses can be present in about 20% of patients, but it's not very common, and Kussmaul's sign is more prominent. So let's move on to invasive hemodynamics. When would you get an invasive study on constriction? So like I said, with clinical suspicion and echo, you may diagnose it in about 75% of patients, but in reality, and if you look at all the hospitals around the country, we don't really get great pictures on everybody, right? So acoustic windows are important. So if you don't have very good images, you move on to the invasive study. Also, if you have a contribution from other diseases, if you think there's a myocardial dysfunction as well, there's a valvular pathology, you might want to do the invasive study to put a final answer on it. So hemodynamics are dynamic during respiratory cycle, just like echohemodynamics. You look for increased ventricular interaction. So that would be your answer. So this is also a busy slide with multiple hemodynamic tracing. So I'll try to just briefly go over it. So key hemodynamic findings in constriction are increased right atrial pressure, increased atrial pressure in general. You have prominent X and Y descents. And this is from, if you think about constriction and in comparison to the tamponade, constriction is mid to late diastolic phenomena, and a tamponade is holodiastolic phenomena. This is why when you have that RV compressed by the fluid, there's essentially no filling of the heart. That's when they go to PEA. But in constriction, you don't, the RV does not meet that fibrotic pericardium until mid to late diastole. Therefore, all the filling of the heart happens during early diastole, and it happens very rapidly. And this is your prominent Y descent. And we also call it so dip and plateau pattern, or a square root sign in a hemodynamic tracing gives you an idea of rapid restrictive filling. So that can be present in restriction as well. It just tells you that there's rapid filling of the ventricle for the time period that it has in that diastolic phase. So opposing changes of the left to right ventricular filling is a very important thing to look for in a hemodynamic study. And really what you look for here, you see that when the RV pressure is at its highest, there's a drop in the LV pressure. And when there's a high LV pressure, there's lower RV pressure. And really what you look at is at the area, not so much at the pressure. And they have there's a formula of systolic area index where you have in the numerator RV area and LV area in inspiration, and in the denominator RV area and LV area in expiration. And that ratio of about 1.4 gives you pretty high sensitivity and accuracy in identification of constrictive pericarditis. So on the bottom right here, I took this from one of the review articles by Goldstein. This is a wedge pressure and right atrial pressure. And as you can tell here, during inspiration, there's a rise in right atrial pressure. That's your Kussmaul sign. And you can see how wedge and right atrial pressure are out of phase from each other, right? So they normally follow along pretty well, but you see that there's they don't really follow along in a patient with constriction. And on the top here, you see the equalization of the diastolic pressure during inspiration and increased gradient during expiration. Now, the difference between restriction and constriction, if you want to remember it this way, is discordance and concordance of the LV and RV pressure. On the left side, you see patient with restrictive cardiomyopathy. that has concordant changes, drops and decrease and increase in LV and RV pressure, and patient on the right side has clear ventricular interdependence. Now, I'll briefly go over types of constrictive pericarditis. So there's three different types. Transient constriction, there's effusive constrictive pericarditis, and there is chronic constrictive pericarditis. Now, they're the spectrum of the disease. When you look at the transient constriction, it's usually a milder form, and it happens acutely, usually after cases of idiopathic pericarditis. And it can resolve spontaneously without treatment, or you can help resolve this problem with some anti-inflammatory agents. So most common causes are post-cardiac surgery, some collagen vascular diseases. MRI can be useful to look at that late gadolinium enhancement on the pericardium to make you decide whether you want to treat it with steroids or not. But it's usually a milder form, and it's very transient. Now, effusive constriction is when epicardial constriction happens in the presence of pericardial fluid under pressure. That can lead to signs of both constrictive pericarditis and cardiac tamponade. Now, interestingly, sometimes you can't really diagnose constriction without doing a tap. So after you take the fluid out, now you start seeing the signs of constrictive pericarditis. Occasionally, you can see signs of both. For example, you can have pulsus paradoxus, but you can also have loss of Y descent in a JVP, and at the same time, you can have a pericardial knock or signs of right side heart failure. And this third type is a chronic constriction that usually persists up to 3 to 6 months. It's present in about 25 to 30% patients. It's more prevalent in idiopathic, but also in radiation-induced disease. And you see signs of end-stage disease of constriction in this particular type that are cachexia, AFib. They start to have low cardiac output because of the low left heart filling, hypoalbuminemia due to PLE, and they may have cardiac cirrhosis as well. The only treatment for these patients is pericardiectomy. Now, this is an interesting tracing of a patient with effusive constrictive pericarditis. On the left-hand side, these are tracings before TAP. On the right-hand side, after the pericardiocentesis was performed. Now you can see here, there's a clear blunting of the Y descent on this right atrial tracing. There's an elevated right atrial pressure. There's also elevated RV EDP. But once you take out the fluid, you see the clear rapid Y deceleration and X deceleration. So it's rapid atrial relaxation and rapid atrial emptying. And you can start seeing the square root sign on the RV tracing. So this is how you unmask the constriction after pericardiocentesis. Now, when we move to treatment of pericarditis, I'm not going to talk a lot about different treatment modalities for constriction. Now, we all know the main treatment is pericardiectomy, or get rid of that layer of pericardium that causes heart to inability for heart to distend. And in a lot of cases, it's a curative treatment. But also for some of the specific etiologies like tuberculous pericarditis, you may consider treating with antibiotics or anti-tuberculous agents in order to improve constriction. And in certain cases of transient constriction, you may consider using steroids or anti-inflammatories to help resolve constriction as well. Sometimes patients are so end stage that they carry a very high risk of surgery. So in those patients, we sometimes opt for medical treatment instead of pericardiectomy. In fact, this is what I meant by not waiting too long. The early diagnosis is important in these patients. The surgery is very challenging. Not every cardiac surgeon can do pericardiectomy. There are specific centers where they refer for these procedures. Now, in the last couple of slides I have on outcomes and prognosis of patients with constriction, and then I have a few cases that I'm going to go through. So this study from Cleveland Clinic they followed these patients for many years, and what they found is there's certain etiological types of constriction that have worse survival than others. For example, patients with idiopathic have excellent survival, as you can see from this graph, and patients that had radiation disease have the worst survival, about 27% at 7 years. And this is probably because radiation not only causes constriction, but also has a lot of adverse effects on the heart itself. So it can cause concomitant valvular dysfunction, CAD, myocardial disease, and constriction. So those patients are sicker, probably for a lot of reasons. From this study, they also found that advanced age, LV systolic dysfunction, high pulmonary pressures, higher creatinine, and lower sodium were associated with poor survival. And there's another one from Mayo. They have looked at about 135 patients and 119 who survived the pericardiectomy. At about 4 years, they found that 85% were either asymptomatic or mildly symptomatic. And survival at 5 to 10 years was 78 and 57% compared to age and sex matched U.S. population. So at about 10 years, half of these patients were still alive. Okay, so I have a few cases that we'll go through. First one is a 64-year-old patient with non-ischemic cardiomyopathy with EF of 20%, a history of AFib and hypertension. He had a prior hospitalization for large pericardial effusion that was tapped, sent for analysis, was non-malignant. He presents to our cath lab for right heart cath, referred by his cardiologist to assess the cardiac output, cardiac index, and thinking that the right heart cath thinking that this is all heart failure. So this patient, one thing I want to also mention that it's very easy to do a constriction study. So if you ever have suspicion, all you have to do is, in addition to your right heart cath, get a 4 French arterial access and get a catheter into the ventricle and look at these changes in real time. So this patient had, on his exam, there was a clear Kussmaul sign. And the S3 sound of pericardial knock you could hear as well. He had no edema, warm extremities, and nothing else revealing on the exam. These are echoes, sorry. So these are apical shots of his LV and RV, his heart before the tap. So he has a large pericardial effusion that was located mostly next to the RV that was tapped. As you can see, you can't really tell anything from these pictures, whether the patient has septal shift or any other clear findings of constriction. Now, this is his Doppler findings, and so there's on the left side, this is a mitral inflow. You can see there's a clear variation in the mitral inflow. But also, when you look at the tissue Doppler, if you try to reveal annulus reversus, if you try to see the higher mitral annular velocities, that he doesn't have any. And keep in mind that this patient also has myocardial disease, so it's a mixed etiology. It's not clear constriction. Now, this is his echo after the pericardiocentesis. Now, in retrospect, looking at it, I would start looking at that septum more carefully, even though there's no respirometer, but I could see maybe there's something happening to the septum during inspiration, but really not so clear. And then we decided to do a hemodynamic study. We decided to do constriction. So his index came back low on the right heart cath, and also, as you start seeing, this is a RA LV pressure, and on the bottom is wedge LV pressure. So you can see the gradient well above 5 millimeter mercury during expiration, and during inspiration, there's equalization. So this was one of the hallmarks of constriction, and the other one was LV-RV pressure. You can see the square root sign looking dip and plateau in RV and LV pressure, and then there is a equalization during inspiration and opposing changes when your RV is at the highest, the LV is in the lower range compared to the previous beats. So he got an MRI that showed very thick pericardium, about 7 millimeters. They actually found a lot of fibrosis in the LV, which they thought that he may have had myocarditis in the past. That was the primary reason for his LV dysfunction. They saw clear flattening of the interventricular septum during early diastole. I couldn't get the pictures because the patient had a pacemaker as well, had a lot of artifacts, so they weren't really that great pictures. But this was happening in a real time with the inspiratory phase. They also found that he had low inflammatory markers, but we still decided because of that thickness of the pericardium and a lot of inflammation to give him a trial of anti-inflammatories for a few months. So this patient on the follow-up did not really get better. He doesn't feel much better, so I think there'll probably be referral for consideration of pericardiectomy. Second patient, 73-year-old, history of borderline reduced EF, diastolic dysfunction, hypertension, diabetes, who also had pericardiocentesis 3 weeks prior, and unfortunately had RV wall perforation by the wire, and had hemopericardium, which was also drained. So about 850 cc's of bloody non-malignant fluid came out. Since then, he was admitted several times for diastolic heart failure exacerbation. Now, this is this patient's echo before pericardiocentesis. Just by looking at it, I would think like this patient is probably in tamponade, but there's clear RA collapse. There's maybe some RV collapse. The heart is swinging in the heart. There's large swinging in the pericardium. There's large circumferential pericardial effusion. There was some other studies that were, mitral inflow and tricuspid inflow were consistent with tamponade physiology, so it was drained. He had a dilated IVC. Interestingly, he's M mode. As you can see here, this is a respirometer. During inspiration, he had a shift as well, shift of the septum to the left, which you can see in tamponade as well. It's not very specific sign. So this is several weeks later when he came in. Again, we got this echo. There's still some pericardial effusion. I want you to pay attention to this part right here next to the left ventricle. There's some thickened material. I don't know if you can see it well. There's some thickened material and probably old clots from prior hemopericardium that seem to be restricting the expansion of the LV. There is some septal bounce, although not very apparent here, but during inspiration there's clear shift of the septum. Now this patient had early diastolic hepatic vein reversal on a Doppler study, and this is his transmitral and transtricuspid Doppler, which shows not so much on mitral, but on tricuspid you do see about probably 40%, 40 to 50% variation. So his findings weren't subtle on the hemodynamics. When we did the RV, when we did a constriction study, he had very clear ventricular interdependence, apparent on this top picture here. And he did have equalization during inspiration. So this patient went to surgery. He had an effusive constrictive case. We think, they most commonly happen after hemopericardium or if you had blood around the heart. So he went to surgery, and he didn't have pericardiectomy, but he had decortication of the heart. So they took out 600 cc of old bloody material, and they stripped the heart from all these clot and fibrinous chunks here. And there was a peel that was covering right ventricle that they also freed from constriction. By looking at the pericardium, they said it looked very good without disease, and there was no calcification, so they left it alone. And in fact, patient is doing much, much better. So his pressures have come down on the right heart cath after this, and he was discharged home, and on follow-up clinic visit, he was feeling well. And this last case of 78-year-old woman with not a lot of comorbidities, had diabetes, and left hip arthroplasty prior to presentation. She comes in with a chest pain that's very classic for acute pericarditis. She didn't have typical EKG findings, but had chest pain and pericardial effusion. So we treated her for acute pericarditis. Now she started having symptoms of heart failure on the next day, so she had started having low extremity swelling, some orthopnea, elevated JVD. So we sent her to the cath lab to do constriction study. Now her etiology was likely idiopathic, but she did have an AKI during this admission, with BUN rising to 55 from 13. Unlikely to be uremic, but something to keep in differential. She didn't have any significant exam findings of constriction other than elevated JVD. Now her windows were great as well, so there's one picture of the apical four-chamber. There's some effusion here, but you can't really tell anything else. Transtricuspid and transmitral inflow variation is notable. She also did have some early diastolic hepatic vein reversal and a dilated IVC. So all these findings, they hinted towards doing the constriction study, and she had the same as our previous patients, the changes of RV and LV pressure and equalization in diastole during inspiration. And as I said, remember this gradient should be above 5 to think about constriction, and this patient's gradient is about 10. Okay, so she was treated with anti-inflammatories. We call it a transient constrictive pericarditis or early constriction, and that's because her index was still normal. So index was 2.1. She was treated with anti-inflammatories. She also did really well. So some of the take-home points. I know this was a lot, but a few things to remember. Constrictive pericarditis, commonly misdiagnosed as a diastolic heart failure, should have good clinical suspicion. It is potentially curable cause of heart failure. I would encourage you to use respirometer with echo studies if you suspect constriction. Echo findings can be useful and actually diagnostic of constriction, but most of the echo images aren't perfect, and so we still go to the hemodynamic study where we finally can answer this question. MRI can be useful to look at the hemodynamic effects as well as the inflammation of the pericardium. The treatment of pericarditis is pericardiectomy. It's a gold standard. But also you may try some anti-inflammatories for a few months, including steroids, if you have a lot of uptake on MRI and signs of a lot of inflammation. Prognosis of the constrictive pericarditis is variable based on etiology, and the worst survival was seen in radiation-induced constrictive pericarditis. I want to thank Dr. Sorescu, Dr. Jabber, Dr. Bod, and ready for questions.
Surgeons always talk about when you're trying to take off the pericardium. When you're trying to take off the pericardium, it's much like peeling an orange.
Exactly.
You'll have little stretches that'll come loose very nice, and then others will come out as you take out. So
It's actually very interesting. When I looked at this, there's a big review article on constrictive pericarditis and treatment. When you go to the surgical section of the management, this would have been too much for this 1-hour talk, but there are several techniques of how to strip the pericardium, including with the sparing of the phrenic nerve or sacrificing the phrenic nerve. So that's what I meant, but you have to be very, very skilled surgeon to do this procedure. It's very complex, so not every CT surgeon does that.
So that's correct. Surgeons don't like to see these people coming. It is like peeling an orange. I've had the opportunity to go down and watch them try to do it. The trouble is sometimes it doesn't peel. They wind up trying to dissect it off. The marginals are in the dissection. It's just a disaster. Sometimes it's impossible to do thoroughly. They'll come out and say, well, we got most of it, but not all of it. So as a result, recovery is slow, drainage is long, and results are not perfect. So I like to, we all study neck veins throughout our career trying to understand that, what they mean. But in going to the bedside on these patients around here on 4G, the rapid Y descent somehow always catches my eye. But if you watch the house officers look at that, they are focusing on positive waves. So you got to try to focus on negative waves. If you see a big negative wave, when you walk in the room, the odds are that is a V wave. And sometimes, if you do better looking at it from afar rather than real close with a light. And that negative Y, the big Y descent, is a clue to the fact that at least think about constriction. You have to think about it. The trouble is, we don't think about it enough. It seems to me when the surgeons try to take this off, they have to like chip it off. And as I said, it's very difficult to get off. But probably miss that a whole lot. And some people we have with x-rays that look like the one you saw with the calcified pericardium, we like let them walk out the door. I remember I had a doctor one time that had an x-ray like that. And we talked about taking the pericardium off, and he said, well, I believe I'll just do the best I can with what I got. So don't always send them to surgery. That was very good, Nick.
Thank you. Thank you very much.
The preceding program is copyrighted by Emory University.